Hey everyone, we are back. It's another episode of the Vasculitis Visionaries podcast. Kaley Bynes is here. I'm Ben Wilson, here after our little post-VF pajama party. Not really a hiatus, just kind of a mini July 4th vacation of sorts. You know, we had to bask in the glow of the successful PJ party, helped raise almost $35,000, which was a really fun night to be a part of. And now Kaley, we're kind of back on the horse, continuing a really exciting series of medical guests, starting today with somebody who has probably as much experience as anybody we've talked to, and both domestic and international experience to that effect as well, with Dr. Eric Madison. So this is an exciting time for all of us.
It is. I am finally woken up from my food coma post pajama party. So pretty excited today. Really interesting international experience. I've been looking at some of our metrics for who's listening to the podcast, and there are some non-U.S. listeners. So shout out to them if you're listening right now. And I think it'll be a great opportunity for us to get Dr. Madison on, both to hear about his domestic experience in the U.S., but also some international experience as well, as you mentioned, and kind of broaden our horizons of the podcast a bit.
Right. Yeah, and I know from just from past experience with the VF, we've had there's a good amount of Canadian presence who has listened to us in the past, as well as in Europe as well. So we're definitely excited to always bring in more listeners wherever you are listening from. And as far as Dr. Madison himself, Kaley, I know he is at the Mayo Clinic now. Like we were mentioning, he's done a lot of different work overall in the vasculitic research department, is doing a lot of current research as it relates to some of the current COVID type stuff with lung involvement and all of that, which is obviously extremely important and very urgent right now. We'll ask him a little bit more about that, but needless to say, somebody who has done a lot overall, and as a result now on the faculty, right, there at Mayo Clinic?
Yes, emeritus professor of medicine and rheumatology.
There you go. So that is Dr. Eric Madison. That is our little introduction as well. We hope you enjoy this conversation. We'll ask Dr. Madison about a lot of that current research he is doing, as well as some of the historical stuff he has looked at, because he does have a wealth of knowledge about everything. And I'm sure, Kaley, with you and your Masters of Public Health and all of that, you will be very excited to ask a lot of historical, deep dive kind of stuff about
Ready
that.
to nerd out as always.
As always, yes. All right, so we are back. It's another episode of the Vasculitis Visionaries podcast. Dr. Eric Madison coming up right after this. Okay, we're bringing in now from Rochester, Minnesota, with his work at the Mayo Clinic, Dr. Eric Madison. Dr. Eric Madison, thank you so much for coming on the Vasculitis Visionaries podcast. It's just kind of a rare treat. Not only have we been looking to have you on for quite some time, but so many of our guests on the East Coast, right next to where Kaley Bynes, my co-host, is in Maryland. And so now you're joining me. You're here in Minnesota. I'm in Wisconsin. Nothing like the upper Midwest and the North Woods in summer. I feel like we can all agree on that, right?
Absolutely. Well, thank you.
Yes.
I appreciate the invitation, and I'm a longtime researcher, investigator, and clinician in the field of vasculitis and other autoimmune diseases. My other area of concentration besides vasculitis is actually still rheumatoid arthritis. And I've had the pleasure also of working with the Vasculitis Foundation for many years. And so I've gotten to know the patients, the families of patients, and the organization, and the good that it does in disseminating important information about vasculitis and vasculitis awareness.
And of course, the Mayo Clinic's been a big factor, has played a big role in that. As we remember, those of us involved with the VF, our international symposium last summer in Rochester, Minnesota, and I know a lot of your colleagues, Dr. Madison, spoke at that larger symposium, and you've been a part of those events in the past. So given that, and we're going to get into some of your history, you've been around this community for a long time, and you have a lot of great insight, especially for medical professionals who listen to this podcast, about some of the current research, but also historically and how everything relates in the field as a whole. But I want to ask first just some of the research you're doing right now, because it seems like we're always in that scope of trying to learn more. And you mentioned just a second ago about some of the focus points that you have. So what's the latest on your end?
Well, currently, what I'm working on is a evaluation of outcomes that we should be using in the diseases giant cell arteritis, which is the most common form of idiopathic inflammatory vasculitis, and its related disease polymyalgia rheumatica. There are really no agreed upon outcome measures that are consistently obtained in studies that evaluate the effects of drugs for these diseases. And of course, also in the clinic, we're trying to learn what we should be doing to better assess the disease state, the disease activity, and the damage that the diseases cause. We're examining the role, for example, of different types of imaging, what imaging, such as PET or MRI, how much, how often, in whom that should be done. Are there biomarkers otherwise that we can use more effectively in evaluating the course of the diseases and helping people to better manage the treatments for the vasculitis? And then I've also had a very long-standing history in interest in the way the lung is involved in these autoimmune diseases. I've concentrated my work in rheumatoid arthritis, seeing how rheumatoid arthritis affects the lung, how it causes inflammation in the lung, how it causes scarring in the lung. But this process of inflammation and scarring is not unique to rheumatoid arthritis. It occurs in other autoimmune rheumatologic diseases, including many forms of vasculitis as well, most particularly EGPA and GPA. And so we have done quite a bit of work to assess actually how often this happens, what the survivorship impact is, and also looking at the biology of these diseases. Currently, we're actually studying how the inflammatory process is triggered by the COVID virus and what similarities and differences that has to what we see in autoimmune inflammatory lung disease.
Very timely research, as I was saying earlier. I think it'll really be important, especially as we're looking at increasing COVID numbers, unfortunately. The other thing that I wanted to transition a bit here is that in addition to all of your ongoing research and this paper that you're working on publishing right now, you also have a reputation as a medical historian. So can you talk a little bit about how understanding the history of diseases like vasculitis can inform diagnosis and treatment?
Yes, so for many people, the study of medical history is seemingly esoteric and really unrelated to day-to-day practice. But I think that actually there is a very strong reason for us to understand a bit about the history of medicine, knowing where we came from, knowing how we arrived at our understanding of diseases, but also not just from a sort of intellectual exercise standpoint and out of curiosity, although those are main drivers, or major drivers, I should say, for me, but also because I think the study of the history of medicine puts medicine among the humanities, which is really where it belongs. And what I mean by that is that the humanization and study of humanities among physicians is really important from a standpoint very directly today of medical ethics. And I think that the history of medicine teaches us things about professional responsibilities, and hazards and missteps that have occurred in the past and continue to occur today, and helps us to know where we the intersection of medicine and the sociology of science come together. And I think that it's not possible really to understand medicine unless you have some background, and in our case, Western, but this is true of every culture and society. The background of that culture and society's philosophical and political commitments, and I think that it is, as I said, something that can help us to understand mistakes that we have made in medicine. We'll talk a little bit about the ethics of experimentation, human experimentation, that have occurred in very many countries over the years and decades and even centuries. And this, I think, is integral to the conduct of a patient-oriented, humanistic, and ethical practice.
Seems like something that is I don't know, maybe I'm wrong in this, Dr. Madison. I feel like it's a concept, though, that is easier said than done, just when you look at the hectic nature of physicians and how everything is seemingly always ongoing, especially right now when we talk about the current pandemic and all of that. How would you evaluate how we're doing when you look at it from a medical standpoint? How are our doctors doing when it comes to applying those kind of theories in their own practice and relating it to diagnosis, which, as we've talked about a lot in the past on these episodes, is kind of our ultimate goal to do better in that regard?
Well, that's true, and I think what the history helps us to do is to take better histories from our patients. So understanding medical history and the confusion about different diseases is something that we directly apply when we evaluate a patient who has a set of symptoms that are uncertain. And as we think through what the cause of these symptoms are, we develop a history for the patient. And that history is really not unlike an understanding of all of the symptoms, signs, and diseases that have been recognized in the past that form a part of our learning, a part of our training, and shape the way that we make diagnoses today in patients. And so I think that, as you say, the daily practice of medicine is very hectic, and this isn't something that is at the forefront of our thinking, this idea of the history of medicine, when we are in the midst of a complicated evaluation, but it is a architecture for the evaluation of the patient that is applied when we are involved with that patient in the office visit.
I think you make a really good point about how really the history can help you understand the symptoms and signs of diseases, and as you mentioned, shape that diagnosis, which actually brings me to a point that you've made in some of your other work and other podcasts that you've been a guest on, where you talk about the importance of naming diseases for their pathologies rather than for people who claim to have discovered them. And, for the vasculitis world, that comes to mind with Wegener's and how that was renamed GPA based on Wegener's connection with the Nazis. So when naming a disease, especially something as complex as any rheumatological disease, but especially vasculitis, how do you hone in on specific pathologies? Are you concerned that a focus that's overly specific on certain pathologies could affect diagnosis or even potentially allow medical professionals to miss cases of this disease?
I think that that's true. And on the other hand, out of the history of medicine, the case also is that when inflammation of blood vessels was finally recognized in various ways, beginning in the early part of the early part of the 19th century, there was a thought that after inflammation could be seen, that all inflammatory diseases that might affect blood vessels were the same. And we know as we evaluate our patients, and we know from our medical training, which actually comes from this medical history, that this is not the case, that a patient who is presenting with symptoms and signs that in some way reflect inflammation in the blood vessels may have one of any number of diseases. And so the medical history part of that is really how, starting with Adolf Kussmaul in 1865, 1866, and the first description of polyarteritis nodosa, which he and Rudolf Meyer, his pathologist, called periarteritis nodosa, was a signal discovery that for years after that, all physicians related inflammation of blood vessels too, but then it served as a way to differentiate specific disease patterns, what we know today as microscopic polyangiitis, and then later GPA, for example, and many other forms of vasculitis, like hypersensitivity vasculitis, for example, or what we call right now Takayasu arteritis or giant cell arteritis, how they are different from these index cases. And when we're in the clinic, we think the same way. And when we're thinking about that, what we're really thinking about is how do those symptoms reflect what's going on in the body? And one of the ways that we approach it is to consider, could this be, in the case of vasculitis, a vasculitis that affects small blood vessels or medium-sized blood vessels or large blood vessels? And already there, we introduce the idea that the pathology is actually more important than a given name that really doesn't help us to understand the disease at all. So Kussmaul, interestingly, never gave polyarteritis his name, and nobody ever thought of giving polyarteritis nodosa Kussmaul's name. Curiously, especially in the 20th century, in terms of vasculitis, for example, Takayasu arteritis or Wegener's granulomatosis, those diseases were not named because of the desire of the individuals to have them named for themselves, but it turns out that they were actually named for more jingoistic reasons. In the case of Takayasu arteritis, that wasn't until 1941, and you can see it in the context of expansion of the Japanese Empire and Japanese science, and with Wegener's granulomatosis, that was actually not Wegener's idea, but the idea of a couple of other physicians who thought that Wagner was the first person to describe Wagner's granulomatosis. So when we give a name like Wagner's granulomatosis, or we talk about a disease like Henoch-Schönlein purpura, for example, which is an older named vasculitis, it gives us absolutely no insight into what goes on with that disease. And actually, in some cases, these diseases get multiple names. So in the field of arthritis, for example, there are a half a dozen names for a disease that we call ankylosing spondylitis today that have emerged over the course of the last century. And depending on what country you're in, you pick your favorite person and you name the disease for that person. And in another country, the disease has a different name. One of the really curious things in vasculitis is that giant cell arteritis that we mentioned before, the most common form of idiopathic vasculitis, is known in France as the malady of Horton. Horton was a neurologist at the Mayo Clinic who identified the disease in 1932 and who had the first biopsy done of a patient with vasculitis, a living patient, and discovered the characteristic findings, the giant cells in the blood vessels. And they called it giant cell arteritis or temporal arteritis. But it turns out we don't talk to our students here about Horton's disease. We call it giant cell arteritis. And in fact, Horton was not even the first person to describe giant cell arteritis. It was already described in 1890 by Jonathan Hutchinson in London. And actually, there are accounts that may date back to the 11th century in Persia that could be giant cell arteritis.
Wow.
So when we come to thinking about Wagner's granulomatosis, that disease, as described by Wagner in 1936 and then in 1939 again with a couple of other cases, was actually also not the index description of the disease. Wagner is not the first person to have identified or described the disease, so it's inaccurate already in that sense. And then there are the concerns, and these are the ethical concerns about what the role of the physician was. In Wagner's case, in Nazi Germany, he was a concentration camp so-called physician. And he did examinations of people who died in the ghettos and who also were sent off for extermination. And he probably oversaw a group in another city, Posen, that was involved in medical experimentation. We don't know that Wagner himself was involved in that, but I think that this calls into question the appropriateness of naming, and it calls it into question for these two reasons. One, or for three reasons, really. One is, who do you name it for? Why don't you name it for the person who makes the first description? Secondly, why don't you call it what it is from a biological standpoint, which is what we do today, GPA? And thirdly, the ethical considerations. That's not the only disease that was named for Nazis are very many others. Hallervorden spots disease, for example, is a brain disease of unfortunate children that was named for a Nazi physician who did autopsies on unfortunate children who met their end at the hands of the Nazis. And I think that on the other side of it, we also have interesting examples in vasculitis of other diseases where a disease, MPA, or microscopic polyangiitis, it turns out, was first described coherently by a Jewish doctor, Dr. Friedrich Wohlwell, in 1922, 1923 in Hamburg. And in 1933, he was thrown out of his lab, his office, by the brown shirts. And he was able, with his family, to flee to Portugal and then subsequently to the United States. And as it happens, Wagner was a member of the brown shirts, the SA, even before Hitler came to power. So we see how complicated these relationships are. And there are many other examples. There's another example in our field, Betcha Disease, which is a disease of autoimmunity that can be associated with vasculitis as well. And Betcha was a Turkish physician who was working in Vienna in the late 1930s who described 2 cases of this disease, but it turns out that about 10 years before that, a Greek doctor, Adamantiadis, also described this disease. And in France, curiously, this disease is known as Adamantiadis-Betcha disease. How helpful is that for us in understanding the biology of this disease? Not at all. And so the redundancy and the inaccuracies of the disease naming according to the eponymic descriptors are really not helpful, although they are of historic interest. And I have to admit that as a medical student, I was fascinated by already the history of medicine, the history of the study of our diseases. And I was very fond of eponyms, and I learned hundreds of eponyms, probably over 600, and was sort of the eponym master in my medical school and residency. Sort of had a reputation for that. But in the meantime, I have in further study, I think that they are important to know, but it is more important really to have an understanding of the diseases. And it's also important to know where the knowledge came from, as I alluded to previously.
That's quite a history lesson and a somewhat jarring one at that, but I mean, it does, I think, shape, and it should shape how we think about this stuff on a large scale. You mentioned earlier the biopsies back in the early 30s. I couldn't help but think of my own PTSD around biopsies and wonder what that patient experience was like in 1930 of getting a biopsy. But nevertheless,
I would wonder that too. And we don't know, actually. I've read those medical records, and we simply don't know because those kind of things weren't kept track of. There was no such thing as, there was no informed consent. There was probably a discussion. They probably had some some discussion with the patient about what the risks possibly could be, but there's no recording of any of that kind of thing.
Right.
Those are things that have also emerged as a result of our history. And in fact, the idea of informed consent really only came into practice in 1957 following a legal case called, I think, Leland and Stanford, and I don't remember exactly what the case was called, but it was Leland versus something. Anyway, that's when our at least in this country, first ideas about informed consent came into practice.
Kaley, have you had a biopsy? I assume you probably did, right?
I did, and it's interesting that you bring in informed consent, Dr. Madison, because I think it's really hard to get informed consent. I was under a lot of painkillers when I was giving my quote-unquote informed consent to get a biopsy of my kidneys, but I'm glad that at least the thought was there.
Yeah, and and what is the informed consent really, in the end, is an educational tool. That's really how it's intended to be. It's so that there's some understanding that the patient understands what's going to happen to them. And that's the most important way to look at the informed consent. And so it is a difficult thing when your mentation is somehow impaired. There's always these, it's an assessment of, well, how impaired is it? And you as a patient, or I as a patient, I'm not always aware of how impaired or not impaired we are because of some medication that we have been given. And so we have to rely on our physicians or whoever is obtaining the informed consent and who also is accompanying us. And that's where the idea, circling back to medical ethics, comes from. And the medical ethics lessons that we have learned that have led to this idea of informing patients, which stem out of experiences like the Nazi experimentation, but also in this country, for example, the syphilis experimentation in Black men in the 1940s without their consent. All these kind of things are lessons from medical history that we actually do incorporate into our day-to-day practice now.
And the other thing, just you bringing up all this historical stuff and how it's appropriated to currently and how we view everything. And another thing Kaley and I have both, as I think any patient has gone through, is prednisone and how the changes that we've seen to that over time. Kaley, you can echo me on that, right? You as a public health student, and now in your career, I'm sure you've tried to look into that as well. No, I mean it's kind of a big deal for us.
Oh, yeah,
I do have opinions.
Yeah.
just a couple, I'm sure, right? Yeah, and I mean it's but I think too the ongoing research into those side effects and now what we know about it as a whole and how we administer that, I would imagine, Dr. Madison, that's a big part of your current study, and it all kind of relates back to some of the historical data we've seen since, say, the 50s when prednisone started to become such a big part of treatment.
Right, yeah. And before prednisone, there was nothing. And so prednisone made a huge difference in the management of autoimmune diseases. There's no question, and its role continues to today, but also over time. We have a large body of experience and evidence that tells us what the problems of prednisone are. And one of the major endeavors in every field where prednisone has been used is to try to find another drug, a better drug, a drug that's more effective and has less side effects than prednisone. And that has been a very long road in the field of vasculitis. For example, in GPA, as you're well aware, the initial non-prednisone treatments were very heavy chemotherapies. And those chemotherapies, although they did in GPA, for example, very substantially improve the life expectancy of people who had GPA, were also associated with lots of serious side effects, including major infections, cancers, and a risk of death associated with the treatment itself. And so as time has gone on, we've gotten a better understanding of the biology of these diseases, and sometimes by rational intent, and sometimes by guessing, really, that a drug could work because of the general way that we know that it affects the immune system or has had a beneficial effect in other diseases. We adopt a treatment such as Rituximab for GPA and other forms of vasculitis and try it out in vasculitis. And that's exactly how that came about. So the Rituxan use happened here first at Mayo for GPA, and the idea to use it was based on the experience in other rheumatic diseases and also some knowledge about what happens in the biology of vasculitis. But as the scientists and physicians and patients too know, that was a drug that was developed for treating specific kinds of cancers, specifically cancers that affect the B cells, and so it was thought of as an anti-B cell drug, and no one really had any great concept that these cells were involved in vasculitis. But these vasculitides are extremely complex in their biology, and it's, as we know, it's not for most of the forms of vasculitis, the autoimmune forms of vasculitis. It's a complex network of inflammatory cells and inflammatory proteins that cause the disease to occur and persist. And so intervening in different places in that network with steroids or chemotherapy, or even more specifically, these B cells that have downstream effects, in this case, had a really positive benefit. And I think that's one of the great advances that we've seen in the last years, that many patients with GPA can get by with a lot less steroids than in the past. And even in some cases, and we're trying to learn in whom exactly, but in some, if not many cases, that drug without the use of prednisone can be effective in controlling the disease. And that's really remarkable.
That really is, and I personally am grateful for the strides that Rituximab has made. I actually am, knock on wood, in remission and have been without prednisone for about 2.5 years now, based on my treatment with that. So that's definitely a huge leap compared to where we even were 10 years ago.
That's true, and that's really wonderful to hear, because before we really hoped for remission, but really we knew that when we stopped the prednisone, the disease, which was always there, would flare up again. We knew that that was going to happen. And it required ongoing prednisone over very long periods of time, years and years, if not lifelong, to keep the disease under control. And of course, you know that it's a very complicated disease. And in some people, it causes problems in the nose, but not really in other organs. In other people, it affects many of their vital organs and is a potentially devastating disease. And so finding a way to reduce the disease activity, to help people live longer, live better, and to live without the side effects, or so many of the side effects of prednisone, was really a key step forward. And for EGPA, this new medication, mepolizumab, is a drug that is also very promising, is approved, and has had, for very many people, a very good effect. And that one, probably more than Rituxan, was actually used in this disease based on a better understanding of the disease pathology. We call EGPA eosinophilic granulomatosis with polyangiitis, and the mepolizumab actually affects a pathway that is involved with those eosinophils. So that actually brings it back to why it's important to describe the disease by its pathology and not by somebody's name. In the case of EGPA, it's Schurg-Strauss, but guess what? Neither Schurg nor Strauss were the first people to recognize that disease either.
I'm sensing a pattern, I think. I did want to actually follow up just based on your conversation about biologics and how those are used now to replace a lot of the glucocorticoids and other treatments that we've previously used. I did read your article in Medical Republic from a couple of years ago. And for those who don't know, our listeners, after retiring from Mayo Clinic back in 2018, you worked at a hospital in Christchurch, New Zealand, and you worked as a rheumatologist. And I was just wondering, you touched on this a little bit in the article, but about the availability of biologics and also just how the healthcare systems compare between the U.S. and New Zealand. And I know for this podcast, we have a little bit of a U.S. tilt just based on Ben and I and our treatment. So I'd love it if you could just give a bit of background on your work in New Zealand and how the systems are a little bit different.
Yeah, I'm happy to do that. I worked in Christchurch. Also had the opportunity to work in Auckland for 3 months as well. And probably the key difference between the healthcare system here and the healthcare system there is that since 1938, New Zealand has had universal healthcare. Healthcare is considered a right in New Zealand. And because it is state funded for everyone, there is, of course, strong state involvement in what drugs are used, what drugs are approved, because the state buys the drugs. And unlike the US, the state actually negotiates with the drug companies for the drug prices, which is something that for example, Medicare is not allowed to do. And that brings down the price of the drugs a lot. Now, it also means that some drugs aren't available or are very difficult to come by because of the fact that they're very costly to the state. They can be obtained if you have private insurance. So about 20% or so of people in New Zealand have supplemental private insurance. Although for most people, it's a waste of money because they get everything that they need through the state insurance. And when we look at diseases like vasculitis, I saw lots of patients with vasculitis there. And I have to say that the medications that I needed to manage the patients with vasculitis, I could get. And the process for obtaining them was very straightforward. It did not take long to get an approval for legitimate use of the agents that I needed. And that to me was a very substantial difference to our system. We have places in the US where we have absolutely the best medical care in the world. If you look at the country as a whole, there is no healthcare parameter where we are at the top. So we're not at the top of immunizations, we're not at the top of child welfare, or child and infant morbidity or mortality, maternal morbidity or mortality, overall survivorship, for example, after heart attacks. There's absolutely no parameter where we're at the top. And globally, we rank probably as a nation somewhere around 20 or so, 15 to 20 among the 40 some industrialized or top industrialized nations. So those are some key differences. Now, I worked as a government physician. I had a salary that was less than in the US. However, it was plenty to live on. The doctors in New Zealand are not starving, and neither are the other healthcare workers. And I think that the other major difference was that they have a kind of gatekeeper system. So all of the patients that came to rheumatology had to be referred by GPs, by general practitioners. So everybody has a home physician, a general practitioner who's their healthcare provider and coordinator. And if that physician can't figure out what's going on, then they refer the patient to the appropriate specialist. What I found was that if the patients had urgent rheumatologic problems, they got seen urgently. If they did not have urgent problems, the time to being seen was probably longer than it is in some places in this country. And there were waiting lists for things like getting hip replacements and so on. People here talk about that as rationing, but we have serious rationing in this country, which is in the form of having no health insurance at all. And so we have millions of people in America who have no health coverage. And that's increasing, unfortunately, right now, as we've been learning because of unemployment due to COVID. The way that the insurance is managed in this country has led to that. And so that's I would submit a very serious form of rationing that we have in this country for millions of people.
Yeah, one of those things, you can look at it, it can feel kind of depressing when you look at being in our shoes, and given that we're in a pandemic and thinking about it, but to an extent, though, you can at least take some positives away from these other systems, and you're in New Zealand, and how we can hopefully someday, maybe in a different post-COVID setting, apply that and think about how it relates to vasculitis. I mean, I think about, you mentioned mepolizumab, and that's something I've been incredibly lucky to be on now for about 4 or 5 years. But you think about a 6-figure price tag, and you combine it with the insurance industry, and it's tough for and I know a lot of people who've been impacted by that negatively, and it is really tough. So I also want to visit New Zealand, Kaley. I don't know if you feel the same way. It's been on my bucket list for a long time. So that's kind of a goal too, once we're allowed to travel again.
Yeah. It is a wonderful place to visit. I enjoyed living and working there. And like every country, I mean, they have their social issues also. They have a substantial minority Maori population that has socioeconomic challenges. It's not paradise there. I don't know where there is paradise, but I think that really the message is that we globally learn from each other, and actually the way that we treat diseases today is very internationally driven. We have international associations and work groups for almost all diseases, and vasculitis is no exception. And so the standards that we develop here, that we develop together with our colleagues in other places of the world, become the standard for care, and they're altered also by the experiences in other countries. And so learning where it's done well and where it's done better is something that benefits everybody.
I think that's a good final word to have, just to, as we wrap up and just think about this as a whole. I know we've been really grateful to have you on the podcast today, and as Kaley, you were mentioning earlier, with a lot of the things you've been working on, and in your own career, it ties in as well to what Dr. Madison has been talking about with us. So I'm sure you've appreciated it as well.
It's been great. I really appreciate more of the historical, anthropological kind of perspective. I think that's a whole nother level of the practice of medicine, and I think that's really interesting and will be really interesting to our listeners as well.
Well, I hope so. Yeah. Well, it's been great talking with you, and I appreciate the opportunity.
Absolutely.
Thank you so much.
Anytime we can get Kaley to nerd out on a podcast, we've done our job. So appreciate it, Dr. Madison. We'll be sure to keep in touch with all your latest work. Best of luck with everything in Rochester. All
right. Well, thank you, Ben. Thank you, Kaley. It's been great.
Thanks again to Dr. Eric Madison for joining us. Great to be back once again on the Vasculitis Visionaries podcast here this week after our short little hiatus, and a great guest to have on. Kaley, it's been great getting to talk to you again, and getting to see you nerd out once again. That is always a time-honored tradition we have on this podcast. I'm glad it could come to fruition, as always, it seems like.
It's a good goal, I think, for every episode.
Yeah, no, I think so. And I will be making those New Zealand travel plans whenever is legitimately possible. We'll see when that actually is. Of course, as always, want to thank our sponsors, GSK and Genentech, for helping make this podcast episode possible. Coming up next, we will have Dr. Mike Putnam joining us in a couple weeks' time. He'll be talking to us about the recently released ACR, American College of Rheumatology guidelines, that have been a mammoth project in the works now for quite some time, over a year, and that'll be really fun to talk to him about. And it's a big project, and it will have a big impact on how we look at vasculitis as a whole. So that's coming up next. Kaley, great job as always. We'll talk to you next time.
Sounds like it.
All right. Until then, we'll see you in a couple weeks here on the Vasculitis Visionaries podcast. For Kaley, I'm Ben, saying so long.